Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
The neurodegenerative disorder, amyotrophic lateral sclerosis, commonly called ALS, results in progressive weakness of skeletal muscle due to degeneration of anterior horn cells and upper motor neurons. Inevitably, the diaphragm and other respiratory muscles become involved, but at different stages of the disorder, depending usually on where the process starts in each individual patient. Now, sleep specialists are frequently asked to help manage breathing problems in these patients, but many may not have extensive experience with the disorder. To help discuss evaluation and management of patients with ALS, my guest today is Dr. Peter Gay, Professor of Medicine and a board-certified pulmonologist and sleep specialist at Mayo Clinic in Rochester, Minnesota, who is a widely recognized expert in this area. Peter, thank you for coming on today. Let us start with the office evaluation of a patient with ALS referred with possible respiratory difficulties. You're a sleep specialist, maybe out in the community. What symptoms should a provider ask about, and what are the most important physical signs to elicit on examination in the office?
Well, thank you for inviting me, Michael. This is a difficult disease to deal with, and focusing on symptoms is obviously a very crucial part of the evaluation. And it starts the minute they come into the door. You can see how they sit on your couch, and whether they come in a wheelchair is obvious enough. And many patients, by the time they are infirmed like that, don't necessarily complain of dyspnea because they're relatively inactive at that time. But they recognize if even bending over or things like that causes them dyspnea, they probably may already have some diaphragmatic involvement. Talking about their speech, family will recognize speech changes early on, recognizing that their cough is suppressed and difficult to clear their secretions. And of course, choking while eating is another very common kind of thing. But well beyond the day-to-day activities, there then become symptoms of changing body position. The striking comment that I've recognized often is, well, I now sleep better in my recliner, and I don't sleep very well when I don't have many pillows underneath me. Maybe some of the symptoms and signs that are given to you on a typical sort of evaluation.
And when you do the physical exam and try and lie the patient down, what should the physician be looking for?
Well, even before I do that, I'll face right at them and I'll watch them sniff. I'll have them just make a sniff effort, and you can often see what you're going to expect when you lie them down. If even their sniff effort is reduced, and looking at in the oral airway, oftentimes it's wide open, but that's your first chance to see a fasciculating tongue. Now, as they're laid supine, some of them won't even let you do that. I usually raise the level of the bed up so it's a gentle drop when I know the patient has significant diaphragm involvement. And then I just see how much I can let them down before they're symptomatic. But say some of them that they actually allow you to go flat and you can have a pillow underneath. Then obviously we're looking at for the sign of abdominal paradox. Now, why is it paradoxical? Well, the diaphragm acts like a piston. So if it goes down and compresses an area that's mostly fluid filled, then your abdomen's going to have to go out to expand when that piston comes down. If that does not happen, and in fact, when they make a respiratory effort, their rib cage is doing most of the effort, then the abdomen will collapse paradoxically as they take an inspiratory effort. And for me, that's a pretty specific sign. It's not a very sensitive one, even when patients have diaphragmatic involvement. But when they have profound paradox, that diaphragm is clearly involved. So that's a helpful sign. And the symptom of the orthopnea, no, 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 don't, I can't go any further, is a helpful indication that they're going to have some diaphragmatic issues.
Good. Well, you've seen the patient, done a clinical evaluation. What are the most important screening tests that this physician or provider should ask for, short of polysomnography, to be helpful in assessing whether the patient needs polysomnography, whether they are going to need respiratory support in this disorder, and having done those tests, what results would be helpful in making that decision?
Okay, I'm going to admit one of my passions has been policy and reimbursement for my patients. And as a policy wonk, I have really two visions here. One as a descriptive one as a clinician, and the other is anything I'm going to do, I have to get paid for. So the things that are going to allow me to assess my patient and also consider reimbursement criteria are in the pulmonary function testing arena and the overnight oximetry arena. Clinically, I think the overnight oximetry is much more valuable. It's focusing on where we are going to provide our additional care and intention to make the patient feel better, and that's with the ventilatory support at night. And in fact, the oximetry, you'll see subtle changes long before you'll see significant changes in the pulmonary function tests. So the subtle, I call them icicles from the Minnesota rooftop that are grouped on the oximetry in a fashion that you can almost play like a guitar chord. They're separated. You'll see these separated areas, usually on a background of a relatively normal mean saturation. Early on, that's very helpful that that diaphragm is showing some reduced performance during the REM sleep stage, where obviously the diaphragm is the only respiratory muscle that's providing the major adequate support. So the oximetry clinically is useful, but it only becomes valuable in the reimbursement criteria when it has sustained saturations for more than 5 minutes cumulatively, less than 88%. Now, the pulmonary function tests are useful as an earlier indicator when the FVC, the forced vital capacity, is reduced even mildly below 80%. And we may talk later about that. The Europeans recognize that as a valuable issue and might want to initiate things now. We can't do it until the patient has profound reduction in their vital capacity, moderately severe reduction of 50%. Their maximal inspiratory pressures are useful for guiding evidence of reduced diaphragm performance and criteria for reimbursement. The maximal expiratory pressure is often overlooked and is useful to remind you to ask them more about cough, because once the rib cage is involved and the expiratory muscles are reduced, the cough and aspiration issues may be a concern. So the oximetry and the pulmonary function tests in that fashion are the most useful thing.
Good. Now, clearly, when you have a patient who's orthopneic, as you discussed, cannot lie flat, distressed at night, there's no question that we're going to offer that patient supportive ventilation at night. But is there evidence that early nocturnal respiratory support, when the patient is minimally symptomatic or pre-symptomatic, delays progression of ALS? And which subset of patients would benefit from early respiratory support?
Let's take the first portion of your question uh, first. That is to say, is there evidence to support early intervention is going to do anything for prolonging life, prolonging respiratory muscle capacity? And admittedly, that becomes controversial because there is no randomized controlled trial, and frankly, there never will be, because there'll never be equipoise in a study where it is the standard of practice now to use NIV therapy. So the question of whether starting early is a benefit. Now, the large retrospective studies, the Italians especially, have a national registry. So they have a huge amount of data, and they have looked at starting patients even with minor reductions in their FVC, less than 80% or so. And there is significant data from their large trials that patients do have some increase in mortality, uh, I'm sorry, increase in survival and reduction in mortality when they start it as early as when the reduction is 80% compared to a trial where they waited till they were 50% or less, as we did. So this has led the European practice to actually change to an earlier NIV offering than we do. But I'll remind everyone of the technical expert panel recommendations that actually came out in September of 2021 that I chaired. And the neuromuscular group felt very strongly that we should follow the European model and urge our CMS criteria to change to less than 80% vital capacity. So in that context, I think at least offering patients who are symptomatic and really want to start earlier an opportunity to do that should be a physician patient decision that hopefully will come with our recommendations to CMS still to be seen. The second part of your question is really, can you kind of spot people that might really benefit from earlier use? And certainly those who come to you with symptoms are really anxious to get something to relieve those symptoms. So if a patient comes in with orthopnea, they're much more likely to tolerate NIV. They're much more likely to benefit from the use of that. It looks like younger patients with preserved upper limb function that can utilize the device and put the device on, they're much more likely to benefit from earlier use. When you initiate NIV closer to when the symptom onset is demonstrated, that's another additional indicator of patients that really benefit from earlier use. So that's what the studies support. And ultimately, the outcome always associates with the more NIV use that you have, the better you're going to do. So again, if you have better tolerance with that initiation in those subgroups, you're more likely to get longer use and better outcomes.
Well, that is really a segue into our next question, which is that adherence to therapy is obviously important. If the patient is not using the system, there's going to be no benefit either symptomatically or in prolongation of life. What factors, in your experience and from studies, have been shown to be most important in determining patient tolerance to non-invasive ventilation, which is not an easy thing for many patients to start using, especially if they're not symptomatic?
Right. I think again, the tolerance correlates strongly with the clinical features that we talked about, particularly the orthopnea, and that the patients who have CO2 retention and reduced vital capacity, they're already advanced disease. Those are the ones who are most likely to be tolerant of that. And there's pretty good evidence that when this is introduced with multidisciplinary care and that the NIV optimization is individualized to that patient, you play with different masks. If they're really having trouble, you accommodate them during nap sessions during the days. There's many different techniques to try to individualize the optimization for these patients that gets you to where you want to be.
Good. So, Peter, as you mentioned, you're really an absolute expert in the reimbursement issues regarding ventilation, and we're really talking about Medicare, Medicaid patients here, CMS, Centers for Medicaid and Medicare Services, but of course, a lot of private insurers have just adopted similar criteria.
Yes.
So CMS has very specific minimal criteria for saying, yes, we will pay for respiratory support at night in the setting of neuromuscular disease if one of the following is fulfilled. Without going into any detail on the discussions of whys or why nots, could you just briefly list the criteria that they will accept?
So you have three avenues, and it is for neuromuscular disease, which is what we're talking about. You have the vital capacity, which is very easy, and it's 50%. you don't really have to worry about a slow vital capacity or a FVC. I mean, you can slide a vital capacity less than 50%, usually is not argued. The maximal inspiratory pressure is usually a fairly easy one because, especially if they have some bulbar disease, they don't couple well with the test, and anything less than minus 60 centimeters of water is a good qualifier. The oximetry is often subtle, and you only remember it's 5 minutes of the whole recording time. It's not sustained 5 minutes less than 88%. So with early diaphragm involvement, that's probably the easiest one to get patients qualified for. So the oximetry, the maximal inspiratory pressure, and the FVC are really the targets for us to get there.
And you only need one of those three, correct?
Correct. Correct.
Okay, so you generally the patient will qualify before you even start thinking about polysomnography. So that allows us to use polysomnography therapeutically to find the best possible machine and settings. We don't have to worry about diagnosis as we do with obstructive sleep apnea. So at Mayo, where we are very specialized in this area, mainly due to your leadership in this field, we have a very specific protocol for conducting polysomnography in ALS patients. This involves a half night on bi-level positive airway pressure in the ST mode and the other half using a volume-assured pressure support system or VAPS. In the morning, we decide which system was most effective, which system did the patient tolerate most, and then we make a decision of which to prescribe. Now, most sleep specialists are familiar with bi-level positive airway pressure, but I suspect that most non-pulmonary sleep specialists who are not working in specialized centers like ours will be uncomfortable with a more sophisticated volume ventilator like VAPS. What do you recommend? How should polysomnography be performed for ALS patients who are not being seen in very specialized tertiary care centers?
I think this might be somewhat of interest to the audience here. Let's play country doctor ALS treatment for just the concept of initially maybe less is more. I'll tell you, in the late 80s, early 90s, when we didn't have necessarily polysomnography around to do it, we started them out with minimum EPAP of 4 or 5s, start them out at an IPAP pressure about 10 and a backup rate of 10 just to start. So the importance here is getting it right necessarily the first night may be too powerful. And if you use a VAPS pressure support and allow the machine to push to a higher pressure level to get to volumes that maybe they don't really want or need at that time, you're going to discourage them. So coming at them hard and fast in a PSG, making sure that your techs understand that job one is to say in the morning, yes, I will use this. So now let's address your question more specifically. Now you have a hypercapnic patient. You really want to take advantage of your polysomnography effort. And as ours, I don't know if you will make the citation available to you, but our protocol is described fairly well. We're starting with a bi-level PAP support. You can, again, usually minimize. It's rare that patients have an obstructive component. Occasionally they do, but most of the time you don't need much of an EPAP. So then the question becomes, how much pressure support do you need to support a tidal volume somewhere over 300 cc's or so? That's a target number to kind of keep in your head. We probably like somewhat more in somebody who's more hypercapnic, but 300 keep in your head. So we use the bi-level PAP device and oxygen saturation during the initial part of our titration to optimize both that sleeping quality and improve that ventilation, which will bring the oxygen saturation up at the same time to give us some indication of how we're going to flip over to uh, the adaptive pressure support, where that peak IPAP level and the volume that we got from the IPAP level that we found was comfortable for the patient during the bi-level PAP titration can be then carried to start your VAP support. So you can use that IPAP pressure and that tidal volume of around 300 to get you going. But again, rather than seeing that beautiful saturation and that idealized minute ventilation, or the target there is to get the patient comfortable first. You can always make adjustments. It doesn't have to be perfect the first night. The most important target is trying to get them comfortable with the device. But I gave you some parameters to look at, hitting them with 15, 18 centimeters of water, upper pressure supports is typically going to cause mask leak, too high a pressure for the patient to be comfortable, less may be more.
So would it be correct to say you're recommending a sleep specialist not particularly experienced in this field, just to use bi-level positive airway pressure, not to use VAPs at all on that first night, and just try to get to a pressure setting where the oximetry is adequate, the patient is tolerating it well, sleep quality seems to improve. Is that an oversimplification?
No, I think that's an excellent recommendation. The idea that this technology was designed, oh, the patient's going to get worse, you're going to need more later on. This is the ideal device to do that. There's not a lot of evidence to support that. In fact, typically these patients are going to be losing weight as the disease progresses, and their pressure requirements may not necessarily get that much bigger. You can tweak this a little bit, usually just with overnight oximetry when you follow them. If they are hypercapnic, when they come back, you can follow with a blood gas, but tweaking later on is easier. If somebody's in a rural environment, if you drop that pressure for that targeted tidal volume too much and you can't reach that tidal volume with a VAP support, it's going to alarm. People aren't going to know how to respond to that. The respiratory therapist won't be as available for these patients. If someone's in a particularly rural area and I don't know the support that I'm going to get from the vendor in that area, I think it's a much better idea to use a bilevel support.
Great. So tell us very briefly about cough assist devices and why one has to think about that as well as about nocturnal ventilation.
I don't think you can really say that patients die of hypoxemia. The hypoxemia, once they're on an NIV support and they ventilate properly, hypoxemia is not going to be the terminal event. Almost always, then it's going to be moving onward towards an aspiration event or a pneumonia as the terminal respiratory issue. And there, managing clearance of secretion becomes a vital part of that. Now, some are obviously much more difficult to handle. Those with hypersialuria who have a lot of secretions to deal with. Um, my typical sort of program is to evaluate both the upper and lower airway kind of concept. You can even hear patients as it's kind of grunt when they can't even produce a cough. And then a cough assist device where they may just pool in the vallecula there. It's just painful that you just want to go in there and reach it out. A portable suction device is often a very valuable thing. They don't have a gag reflex, so you can often get deep into the posterior oropharynx to assist you getting oral secretions out with just a wand, but then a cough assist device to really help that upper airway clearance is a useful thing. Now, our Medicare system, in their wisdom, only allows you one device. And those patients who do develop a lot of plugging, mucus plugging, a lot of atelectasis, and you're really trying to deal with the airway, a chest wall oscillator may be of value in this case. But if you use a chest wall oscillator, Medicare won't pay for a cough assist device. And I think generally the cough assist device is the better adjunct to clear those bigger secretions that you're going to gulp down into the airway. And then we can talk about when trying to be more preventive in risking aspiration and moving to peg tube uh, feedings and things like that is another part of this consideration that you're going towards.
Yes, that's very helpful because that's the sort of intervention that any physician can easily prescribe and start off. Obviously, the disease is progressive, and when it gets beyond early stages and all these other possibilities of aspiration and pneumonia, etc., become an issue, very often the patients ideally should be seen in a more specialized ALS clinic in a bigger urban setting. And that's really not easy for a physician out by themselves in practice to be managing.
Let me mention a simple thing that's often forgotten, and even I forget to say this, that look, this is about prevention. So we do have mass protection and we do have vaccines. These patients all need to be vaccinated.
Hmm. Absolutely. Peter, thank you for sharing your considerable and, as everybody who's heard this, extensive expertise. Do you have any final message to leave with our listeners?
No, I think the focus on the symptomology and how precious life is to patients who recognize their time is limited and focusing on that little bit that gives improvement in sleep. Sleep is their refuge. Sleep is a weapon for these people to restore the best part of their remaining days. So let's do the best we can for our patients with ALS, improving their sleep quality.
Thank you.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.